Bismillahirrahmanirrahim. Quote of the day is: if any Muslim plants any plant and a human being or an animal eats of it, he will be rewarded as if he had given that much in charity. This is the quote by Prophet Muhammad sallallahu alaihi wasallam. Today I will be presenting the topic of schistosomiasis and bladder cancer. My name is Dr. Aamna Khalid and I will present the topic under the kind supervision of Professor Dr. Saira Afsal. So these are the learning objectives of today's presentation. We will go through the epidemiology of schistosoma, the public health burden of the disease, life cycle, the prevention and control, and pathogenesis. Schistosoma is basically schistosomiasis is a neglected tropical disease. This is caused by the blood fluids. Disproportionately affects the impoverished tropical populations. 200 million plus people are infected, and majority of the cases occur in the sub-Saharan Africa, the region most affected. It has a strong cancer link, like Schistosoma hematobium is one of the species which is specifically causing urinary schistosomiasis and bladder cancer. And the endemic regions include Africa and there are parts of Middle East. And also the cases are reported in the pockets of Asia as well. So the global epidemiology that 200 million plus people are infected globally, and 90% of the cases are occurring in sub-Saharan Africa, uh, which poses the highest burden worldwide. The transmission is through fresh water, which is linked to swimming, farming, washing. So the environmental exposure drives the spread of disease. Rural communities, the disease affects low resource areas where there is lack of basic infrastructure and healthcare access. The poor wash infrastructure, like where open urination occurs and contaminates the water sources, enabling continuous transmission. So this is the life cycle of schistosoma. First of all, there are eggs in urine which are released into the fresh water, and this initiates the transmission cycle. Then the melacida, which are present in snails, they hatch and infect the intermediate host, the bulinous snail species. Then the Cercadia, which are released, they are the free-swimming larvae which penetrate the human skin on contact. Then the schistosomiola, which migrate by the bloodstream through the portal and mesenteric vessels. And then the adult worms, they reside in the vesical venous plexus. And the female lays eggs in the bladder wall. So this is the pathophysiology that first of all, as there is egg deposition, the eggs are deposited in the urinary bladder wall, which trigger the host immune response. Then there is chronic inflammation, the granuloma formation and persistent immune activation drive tissue damage. Then it leads to the fibrosis where bladder wall thickening and dysfunction from repeated inflammatory cycles. Then there occurs the squamous metaplasia, the adaptive epithelial transformation in response to the chronic irritation. Then there occurs dysplasia, the precancerous cellular changes due to oxidative stress and DNA damage. And then finally, it turns out into a carcinoma, which is mostly the squamous cell carcinoma of urinary bladder. And this is the end stage malignant transformation. So the clinical features of bladder cancer include hematuria, which is the classic sign, and the terminal hematuria is present in the early disease, which is the pathognomic sign. Then the patient can also present with dysuria and frequency, which reflect that bladder is being irritated and there is ongoing inflammatory process. The bladder wall damage occurs. Chronic infection causes the obstructive uropathy and the structural changes. And the risk of malignancy, there is a significant risk of squamous cell carcinoma of bladder. So there are two different forms of bladder cancer. and one of them is transitional cell carcinoma, and the other one is squamous cell carcinoma. The transitional cell carcinoma is common in developed countries, and it's mainly linked to smoking and industrial chemicals, and rises from the urothelium lining, and this is the most common type globally. The squamous cell carcinoma is linked to the schistosoma hematobium, which is common in endemic regions like Africa and Middle East, and associated chronic inflammation and tends to present at advanced stage. So the International Research Organization for Cancer has classified the bladder cancer caused by schistosoma as a group 1 carcinogen. Means this is a definite cause of human cancer. So the chronic irritation, like persistent immune activation by antigens, promotes a carcinogenic microenvironment. Also, nitrosamines, like bacterial co-infections, produce nitrosamines that act as direct mutagens on the urothelium. The DNA damage occurs due to the oxidative stress from inflammatory cells. This induces the DNA strand breaks and base mutations. In the epigenetic changes, the antigens promote aberrant methylation patterns, altering the tumor suppressor gene expression. So these are the risk factors which are actually leading to the schistosomiasis and then further the bladder cancer. And this include the fresh water exposure. Repeated or prolonged contact increases the infection risk substantially. Poor sanitation. This facilitates the contamination of water bodies with infected urine. Occupational risk, like farmers, fishermen, and irrigators, they face the highest occupational exposure. They are facing the exposure to fresh water. Co-infections like HIV, human papilloma virus infection, and other bacterial infections enhance the carcinogenic processes. Age at exposure, like children and adolescents, have highest infection prevalence. And no safe water because of the absence of the piped water forces reliance on contaminated sources there. So, how to diagnose the disease? First of all, we have the urine microscopy, which is the gold standard, especially in the endemic settings, where it detects the characteristic terminal spine acts in urine. And the second option is ultrasound. This is basically a first line imaging which detects the bladder wall thickening, masses if present, hydronephrosis, and sandy patches. The third one is cytoscopy and biopsy, which is the definitive, which confirms the malignancy, and this allows the direct visualization and tissue sampling. Then the advanced diagnostic is the PCR, which is highly sensitive for low intensity infections as well, but it is costly and not widely available. So, how to treat the infection? The drug of choice is the praziquantel, which is effective against the adult forms, and it reduces the egg burden and transmission as well. And this is present in the list of WHO essential medicines. And if we talk about the cancer management, then there are a number of options depending on the stage of the cancer. For example, we can go for surgery if it is an advanced a cancer stage, like a cystectomy, which can be partial or radical, or chemotherapy, like cisplatin-based regimens are used. Radiotherapy as adjuvant or palliative treatment is used. So praziquantel does not reverse the advanced fibrosis or cancer, but this is basically an early treatment which is essential to treat the infection basically. So now we come to the prevention strategies. We can use mass drug administration, the periodic praziquantel distribution to the high-risk communities. This is the key WHO strategy. Then the safe water supply. This is provision of piped treated water, which reduces the exposure risk significantly. And improved sanitation, like latrine construction, interrupts the transmission by preventing water contamination. And health education, like community behavior change, uh, uh, communication change programs promote the protective behaviors and treatment seeking. Then the snail control. Like we can change their habitat, which reduce the intermediate host populations. These are some of the WHO strategies, are the strategies which are used globally. We have WHO neglected tropical disease roadmap, um, which targets the elimination of schistosomiasis as a public health problem through preventive chemotherapy. Then we have the expanded special project, which is basically focused on the African regions. So they are basically scaling the WASH interventions across endemic countries. Then the Schistosomiasis Control Initiative. This is the foundation which supports and monitors the mass drug administration programs which are running globally. Then UNICEF WASH strategy. The WASH includes the water, sanitation, and hygiene, and this improves the WASH access in endemic communities to interrupt transmission. So WASH will not only help with the schistosomiasis, but with all the diseases which are spread through the poor sanitation and poor hygiene and poor quality of water given to the people. The public-private drug donation programs. Praziquantel can be donated by the is being donated by the Merck organization to WHO, which enables the treatment scale up. So this is the overarching global targets for 2030. The neglected tropical disease global program. The top line targets for the neglected tropical diseases in line with the Sustainable Development Goals and WHO's 13th General Program of Work. So this basically includes that they have the overall targets of achieving 90% reduction in people requiring interventions against neglected tropical diseases, 75% reduction in disability adjusted life years related to neglected tropical diseases, a number of countries having eliminated at least one tropical neglected tropical disease, and two number of neglected tropical diseases being eradicated from the world. So some of the challenges we are facing while dealing with the neglected tropical diseases, or if we talk about the schistosomiasis, which is being a part of it, reinfection is one of the things. Because of the environmental exposure, if it persists even after the treatment, then it will disrupt the elimination efforts in the endemic areas. The second is limited healthcare access, which delays the diagnosis and treatment, and it mostly the most affected live far from the health facilities. The poor surveillance, significant underreporting due to the weak health information systems and the low diagnostic capacity and the provision of the services accordingly. Then the climate change, expanding the snail habitats due to warming temperatures, which threatens to extend the endemic zones northward. So this is a case study which summarizes whole of the scenario, that if a 40-year-old male farmer from a schistosomiasis endemic rural area presents with the long-term freshwater exposure since childhood, and he irrigated the farmland daily for 30 plus years. Now he presents with the painless terminal hematuria since adolescence and dismissed as normal in his community. So the investigations used for the diagnosis were urine microscopy, which showed the terminal spine eggs. Ultrasound revealed the bladder wall thickening. We made the definitive diagnosis by using the cystoscopy and biopsy, which confirmed keratinizing squamous cell carcinoma of the bladder. So the lesson is that this illustrates the tragic consequence of the late presentation, that a farmer who was working since 30 plus years in that area, and since adolescence he had the symptoms of hematuria, but because most of the people had some same symptoms, so he did not present to the healthcare facility earlier at the time where he could be dealt properly, and he presented late. So this highlights that there is urgent need for the screening programs. So the key message includes that schistosomiasis is a preventable, but it remains a major neglected tropical disease, and sustained public health efforts are essential. The second thing is that strongly causal link with bladder cancer is a unique example of an infection-associated malignancy. Then the early praziquantel treatment reduces the long-term complications, and screening is important. The multi-sectoral approach is essential, like health, water, education, and community sectors all must collaborate to deal with such diseases. So now we come to the practice of MCQs. The first question is: a 12-year-old boy from rural Africa presents with painless terminal hematuria. He frequently swims in the freshwater lakes. What is the most likely causative organism? Option number A, Schistosoma mansoni. Option B, Schistosoma japonicum. Option C, Schistosoma hematobium. Option D, Fasciola hepatica. And option E, Tinea sovium. So option C is the right answer, Schistosoma hematobium. Question number 2, a farmer with long-standing schistosomiasis developed bladder cancer. Which histological type is most likely? Option A, adenocarcinoma. B, transitional cell carcinoma. C, small cell carcinoma. D, squamous cell carcinoma. And E, sarcoma.
D.
D is the right answer, squamous cell carcinoma. Question number 3. A public health team is designing an intervention in a high prevalence area. Which is the most effective immediate strategy? Option A, chemotherapy for cancer. Option B, mass drug administration with praziquantel. C, vaccination campaign. D, surgical intervention. And E, genetic screening. So B is the right answer, mass drug administration with praziquantel. Question number 4, a community shows high schistosomiasis rates due to poor sanitation. Which factor is most responsible? Option A, air pollution. B, contaminated freshwater exposure. C, genetic predisposition. D, viral co-infection. And E, poor diet.
D.
B is the right answer. Question number 5, a patient with schistosomiasis is at risk of cancer due to which mechanism? Option A, hormonal imbalance. B, immune deficiency. C, chronic irritation and DNA damage. D, acute infection. And E, nutritional deficiency.
C.
Yes, C is the right answer. Question number 6, a policymaker wants to reduce disease transmission. Which intervention targets the intermediate host? Option A, antibiotics. B, vaccination control. C, snail control. D, surgery. And E, chemotherapy.
C.
Yes, C is the right answer. Question number 7, a child treated for schistosomiasis continues to get reinfected. What is the most likely reason? Option A, drug resistance. B, poor compliance. C, continued environmental exposure. D, genetic mutation. And E, immune suppression.
C.
Yes, C is the right answer. Question number 8, a WHO-led program targets school-aged children for treatment. Why this group is chosen? Option A, highest mortality. Option B, highest infection prevalence. C, genetic susceptibility. D, better compliance. And E, low cost.
D.
B is the right answer. Question number 9. A fisherman frequently exposed to fresh water develops dysuria and hematuria. What is the primary prevention strategy? Option A, chemotherapy. B, vaccination. C, avoid the freshwater exposure. D, surgery. And E, antibiotics.
C.
Yes, C is the right answer. Question number 10. A patient undergoes cystoscopy for suspected bladder cancer. What confirms the diagnosis? Option A, imaging. B, blood test. C, urine test. D, biopsy. And E, stool test.
Biopsy.
Yes, biopsy is the right answer. This is the answer key. This is the YouTube channel of IPH where this presentation will be uploaded. Thank you so much.